Welcome to the Medical Nursing Podcast, the go-to show for vet nurses and technicians passionate about internal medicine. I'm Laura Jones, a registered vet nurse, all-around medical nursing nerd, and your guide to breaking down complex medical diseases into simple, actionable chunks. Each episode is packed with knowledge and tips that you can start using right away to give even better patient care. So let's get started. Hello, and welcome to another episode of the podcast, or a big welcome if this is the first time that you are listening to an episode. You are currently listening to episode 122 of the Medical Nursing Podcast, where we chat all things medical nursing and how we can use more of our skills as nurses and technicians when caring for these often challenging patients. You're currently joining me for the second episode in our endoscopy series, where we are talking all about lower airway endoscopy in cats and dogs. Lower airway endoscopy, or tracheobronchoscopy, or just bronchoscopy for short, is a common diagnostic procedure in our respiratory patients. It's also not risk-free, and if I'm honest, this is probably the procedure that I find the scariest in practice. And to me, that is also probably the biggest reason why I think our role in it as veterinary nurses and technicians is massively underrated. There is one case that will forever stick with me, and that was an oxygen-dependent cat who needed a lower airway scope for a suspected bronchial mass. She had been stabilised as much as possible prior to the investigations, but we still knew that they would be high risk because she was oxygen-dependent, and she wasn't particularly stable prior to anaesthesia. Despite preparing her for these procedures as much as possible, we still saw her desaturate down to 22%, which is absolutely the lowest I have ever seen an SpO2 in a patient that wasn't dead, and became peri-arrest. We saw the heart rate start dropping, and we knew that if we didn't immediately react quickly, this patient was not going to make it. Prompt action from our team of vets and nurses meant that we did prevent this patient from arresting, and after quick intervention, her SpO2 did increase back up again. But it does go to show just how quickly things can change for these patients, and also how preparation and communication from the nursing team and the entire team can make such an enormous difference. And that's exactly what we're going to look at in more detail today. My goal with this episode is that you really leave it feeling completely confident with bronchoscopy cases, both from an anaesthetic point of view, but also when handling with the scopes, assisting with the procedures themselves. We will cover the indications for these procedures, the ins and outs of the scopes we use, how we collect samples from the lower airway, and also just a few hints and tips generally to run these cases successfully as a veterinary nurse, because we really can and should have a central role in these procedures. So I want to start by talking about what the procedure itself actually is, and then we will get into things like the scopes themselves, how we collect samples from these patients, and of course we'll chat more broadly about our role as nurses and technicians. Of course, every patient will be different. There are going to be different areas of the airways that we're more interested in for some patients than others, for example. So maybe if we're only worried about laryngeal function, we're not even going to need to go down into the lungs themselves. But tracheobronchoscopy, or bronchoscopy as it's often called for short, is the umbrella term that we use for looking at both the trachea and also the bronchial tree. So the main stem bronchi that supply each lung, and then the lobar bronchi and the bronchioles. Now, this procedure is almost always accompanied by a laryngeal examination, because we should be looking at the larynx at the entrance to the lower airways in most of these patients, especially if we're concerned about laryngeal function. So all of this means that in most cases, laryngoscopy, tracheoscopy and bronchoscopy will typically happen as one continuous procedure under the same single anaesthetic. It is a team procedure, and I really want to highlight that because when I worked in general practice, we occasionally did these procedures and I never really appreciated how important my role was in them. Back then, I thought my role really was to hold the head up for the scope to be introduced, help with extubating and re-intubating the patient as needed, and of course monitor the patient whilst the vet did the scope. But years of working with these patients and seeing what happens when they go well, and sometimes what happens when they don't, has shown me just how central our role is. Because if we think about it, these patients are not undergoing respiratory investigations for fun. They've got pre-existing airway disease or respiratory disease. If they didn't, they would be healthy and they wouldn't need this procedure. So this means that we can't really predict how they'll respond to things like some of our anaesthetic drugs, because many cause respiratory depression. We can't predict how they react to the scope itself. And also, we will run into issues with things like airway access and oxygen delivery during the procedure, which we'll come on to in a second, and that can make things more challenging. So really, what all of this means is we need to make the entire procedure as efficient as we possibly can and keep anaesthesia time as short as possible. And that means that our role is absolutely vital. So let's chat a bit about what's involved in a bronchoscopy procedure. The first thing that we will do is assess the larynx in most cases. Now, this is usually performed at the time of induction with a laryngoscope under a very, very light plane of anaesthesia. This is important because the drugs that we use can easily depress laryngeal movement. So usually this is happening at induction with very, very little induction agent, and we do it kind of as part of intubating the patient. So what we'll do in this case is the vet will administer the anaesthetic agent as and when they can, sort of when the patient is asleep enough to allow examination. They'll be held as if they were being intubated. Laryngoscope will be used to visualise the larynx, and then whoever is assisting with the induction or monitoring the patient will watch when the patient breathes, and they will say in every time they see the chest wall move when the patient is breathing in. And what the clinician should see is the laryngeal cartilages moving in association with that. So that's the laryngeal exam, that's done first. Once the clinician is happy that they've had a good look at the larynx, the patient is induced, stabilised, and then they are positioned in sternal recumbency with the head and neck extended, because this straightens out the trachea and it makes it much easier to pass the endoscope. When it is safe to do so, the flexible endoscope, which is a bronchoscope, is passed down the larynx into the trachea, and the trachea is examined all the way down to the carina, which is the point where the trachea bifurcates and it splits off into the left and right main stem bronchi, which are the bronchi that supply each lung. From here, the clinician will then systematically examine one lung and then the other. They will pass the scope through different lobar bronchi, which are the bronchi that supply the different lung lobes, and then the smaller bronchioles. And when they're doing this, they are checking each segmental airway for changes in colour, shape, size, for evidence of collapse, for discharge, bubbling, mucus, foreign material, and any other abnormalities. And then they will also, when they're in an appropriate place, usually wedged down in a small terminal bronchus, take a sample for a bronchoalveolar lavage. Now, following this same order every single time and approaching that exam in quite a systematic way is what stops airways getting missed, and it's what helps our clinicians know that they have looked at everywhere. So when you are kind of moving the scope through the patient, the right main stem bronchus, so this is the bronchus that supplies the right lung, is pretty much straight ahead of the scope as it is advanced through the carina. But the left side, the left lung, takes a little bit of kind of manoeuvring to get into. And that is exactly why inhaled foreign bodies like grass seeds or grass blades tend to lodge on the right-hand side, because there's quite an easy path down into that lung. So the clinician will move through the airways, and if they lose their bearings at any point, they will come back to the carina, because that point they always know where they are, because that's the end of the trachea, and they can then reorientate themselves and then move through the lungs again. Now, it's really helpful to actually have a diagram of the lungs near your scope tower to help with visualization, both for our vets and also just for us for interest, so that we know kind of how the procedure takes place. And what I have actually done is I've included a copy of one in the show notes that accompany this episode, so the blog post basically that goes with it. So feel free to grab that from the website, print it, laminate it, stick it with your scope tower, stick it up on the wall near where your scopes happen. It's just really handy to give you an idea of actually exactly where in the patient that scope is moving through, because it doesn't look anything like that on the screen. So it's really helpful. So I'd definitely grab a copy of that. And then, as we said, after they've examined the airways, they will obtain samples. So this is typically achieved using a BAL or a bronchoalveolar lavage. And actually, it's good practice to do this wherever indicated, even if the airways look normal visually, because we often can't see obvious inflammation. Even if it looks normal, we will often get much better results on cytology than, the abnormality kind of looks on the screen. Now, BALs can be performed blindly, so actually they can be performed without a bronchoscopy by just introducing a catheter down into the airways. And if blind BALs are performed, that's typically in patients that have quite diffuse disease where it doesn't really matter that you're not getting a guided sample. But if you do want a sample from like a specific area or a specific abnormality, then that would need to be a bronchoscope guided process. During a BAL, sterile saline is aseptically instilled into the airways, either through the endoscope channel itself or through something like an aspiration catheter. Coupage is then performed by an assistant, so this is typically the nurse monitoring the anaesthetic, for example, and whilst that coupage is happening, the clinician will either be manually aspirating back the fluid with a large syringe or using a suction unit attached to a mucus trap to retrieve that fluid. The idea is that things like cells, bacteria, other pathogens will kind of exfoliate off of the airway walls and then enter that fluid. They become trapped in that fluid, and that fluid is then sent away for cytology, culture, and also things like infectious disease testing where needed. This is a really common procedure, and in fact, BAL happens in virtually every bronchoscopy that we do. And typically during this process, we will instill around sort of 0.5 ml to 1 ml per kilo of saline, up to 2 to 3 times in total, depending on how stable the patient is, also the volumes of fluid we're getting back and how that fluid looks. Now, we won't get all of that fluid back. Usually that doesn't cause too much of a problem because we don't put huge amounts of fluid into the patients. And also the lungs do absorb residual fluid quite easily. But of course, in patients that do have respiratory compromise, we do just need to be aware that we don't want to put loads and loads of fluid into the lungs. So when we're doing BALs, we'll always just check with the person monitoring the patient and make sure that they are happy before we go ahead and perform subsequent ones. A good quality sample is quite frothy. So what we'll often do is put the lid on the tube, give it a bit of a shake, and you should see like a nice little frothy layer at the top. This indicates that we have something called surfactant in the sample, and surfactant is the substance that lines the inside of the alveoli. So if you've got a nice frothy sample from your BAL with surfactant in it, then that's a good indicator that we've actually managed to wash the lungs and got a good representative sample from our patient. Also, it's often cloudy as well. Once we've collected the sample, we're happy with the volumes obtained, the sample is then transferred to plain and EDTA tubes, and sometimes we will make smears of that as well to send away for analysis. One super quick point to mention here from a nursing perspective especially is we do need to be mindful of the risk of contamination, especially if we're doing something like using suction through the scope channel to collect our sample. This is because any contamination of the inside of the scope itself can impact the culture result. So it's good practice to collect something like a pre-culture flush sample of your scope channel by just running some saline through it and then keeping that on hold. That way, if your culture comes back with a weird result and the vet wants to double check to see whether it was a contaminant or not, that fluid that you collected beforehand can be submitted for analysis, and we can actually see if that particular pathogen was already present in the scope before the procedure. Other sampling techniques are also sometimes used in bronchoscopy patients, but less often compared with BAL. These include cytology brush sampling, which is where we take a sterile brush, introduce this through the instrument channel, and then kind of scrape this across the airway mucosa to pick up some cells, and also tissue biopsies, but very rarely do we do any biopsies from the airway. One unique challenge with bronchoscopy is airway access, and this is a really important thing for us to be aware of, especially because it's going to be us monitoring these patients throughout the procedure. So this is a problem because firstly, if we need to visualise the trachea, we can't actually do this fully with an ET tube in place. This usually means that if our patient is intubated, we need to extubate them while we examine the trachea, and then depending on the size of them, we might be able to re-intubate them and continue the rest of the procedure. As we said, it's a bit size dependent, but in some cases you will find that intubation may actually not be possible, and this is especially true for cats and small dogs. Basically, any patient with around a size kind of 5 to 5.5 ET tube or smaller, this is going to be a problem for. The reason for this is because most of the bronchoscopes that we use in practice are around sort of 3 to 4 millimeters in diameter. So if we were to introduce that through an ET tube that was quite narrow, we would occlude too much of the ET tube to keep that in that patient kind of safely. There'd be too much airway resistance around it, and we would just be blocking far too much of that tube for gaseous exchange to kind of effectively take place. This means that some patients, especially our smaller patients, will need to be extubated for the entire procedure. And because of this, often the entire bronchoscopy procedure will happen in short bursts with careful monitoring, pauses in the procedure, and then time for reoxygenation in between episodes of actually putting the scope down into the patient. So what usually happens is the clinician will look for a little while, then they will come out, they will allow time for reoxygenation, let the patient recover, and then when it's safe to do so, they will go back in. And this is another reason why our role in monitoring these patients and communicating with the team is so important. As I said, once the airways have then been fully examined, we will collect samples as needed and then recover the patient. And that is the procedure itself. But there's a lot more to cover here than just the procedure. And what I want to do now is talk to you a bit more about the scopes that we use and what we need to know about them as veterinary nurses and technicians. So tracheobronchoscopy is performed using a flexible bronchoscope. Now this scope is similar-ish to a GI scope, but it's smaller and it normally has less features. We don't need things like air installation, for example, because our lungs should already be nice and inflated. We also don't need to instill water because unless we're doing a BAL, we don't want to be flushing any fluid down into the lungs. And we also don't need four-way movement. So our GI scopes need to be able to move up, down, left and right to move through the GI tract. Our lungs, we don't need to be doing that. We're navigating through much smaller areas. And so up and down angulation only is all we need. Just like our GI scope, as we discussed in episode 121, our bronchoscope has a main body or a handpiece and then also an insertion tube. The distal end of the insertion tube can be bent up and down with an angulation lever on the handpiece, and that allows the clinician to help manoeuvre the scope through those airways. As we said, bronchoscopes are usually around sort of 3 to 4 millimeters in diameter, depending on your individual one, and they usually have a channel that's somewhere between sort of 1 and 2 millimeters in size. This means that they need much smaller channel instruments than our GI scopes. And also bronchoscopes are much shorter, so they will usually have a working length of up to around 60 centimetres. And in small dogs and in cats, that's not an issue. But with larger dogs, we may find that our bronchoscope is actually too short to assess the airways thoroughly. And if that's the case, typically we will require either a longer bronchoscope or sometimes we will use a paediatric or cat-sized gastroscope because that's much longer. And we can actually manoeuvre that through the large airways in our bigger dogs. There's an instrument and suction channel on the body of the scope where instruments can be introduced or fluid can be instilled for sampling when we're doing things like BALs. And as we said, most bronchoscopes do have suction as a kind of an inbuilt feature. So you will find some scopes will have a suction button on the handpiece. This actually allows fluid to be suctioned through the endoscope channel into a collection device such as a mucus trap when we are collecting BAL samples. Inside the scope itself, so if I was to take a bronchoscope and chop it in half so you could see the entire inside as a cross section, you would see that the instrument and the suction channels actually join together to make one large channel inside the scope. So just one thing to be aware of. If you try to suction or your vet tries to suction but there is an instrument inside the channel, it won't be as effective. So suctioning through this scope means that we need to take the instrument out of the channel first. You will also see some people will talk about using the channel of the scope to administer oxygen in some cases. This is theoretically possible because there are adapters that you can get that you can attach oxygen tubing to the scope. But I do just want to caveat this with a bit of a warning. If you are in a really narrow airway, so you're in, a teeny tiny bronchiole, or your vet's in a teeny tiny bronchiole, and the scope is taking up almost the entire diameter of the inside of that small airway, any oxygen that is being administered through the end of the scope is going to be blown into the alveoli below it, and it can't escape. So what this means is when we're in those smaller airways, we can actually be continually pumping oxygen into very small, very specific parts of the airways. This increases the pressure in them, which can cause barotrauma. And also, if we're only administering oxygen to a tiny bit of the lungs, it's not actually giving our patients a huge amount of benefit. So for me personally, if I want to give oxygen alongside an endoscope, so say we're scoping a cat and we can't intubate them, I would rather do something like put a urinary catheter into the trachea and give oxygen that way, because that is going to reach all of the lungs. Alongside the endoscope itself, there's quite a bit of ancillary kit that we need too. This includes things like aspiration catheters for instilling or suctioning fluid, grasping forceps to remove airway foreign bodies, and also biopsy forceps and cytology brushes. And then there's also mucus traps, which I've already mentioned, and these are sterile inline kind of suction traps that actually will collect the BAL fluid if you are performing a lavage through the scope. Just like we discussed in last week's episode, making sure that all of that ancillary kit is damage-free, functioning normally, and unlikely to cause damage to the inside of the bronchoscope, particularly within that channel, is absolutely vital. And also, alongside this, because time is really of the essence with bronchoscopy, we need to make sure that the scope and all of the equipment is prepared and checked in advance of anaesthetising the patient. This episode is brought to you by the Veterinary Internal Medicine Nursing On Demand Library Club, and honestly, if you are not already a member, then you're going to want to hear this. For just £21 a month, you get access to the entire Veterinary Internal Medicine Nursing webinar library. That is over 60 hours of CPD, and it's growing month on month on all things internal medicine nursing, and it's available on demand whenever you need it. And it doesn't stop there. Every single month you get a brand new webinar too, plus access to the monthly evidence files live sessions all included. Whether you want to deep dive into a specific topic or just keep your CPD ticking along, the Library Club makes it ridiculously easy for you to do so. There's no contract, you can cancel anytime, and if your clinic gives you a CPD budget, I can even invoice them directly for a yearly subscription. Think of it as your own personal library card for veterinary nursing education. Head to veterinaryinternalmedicinenursing.com and check out the Library Club to grab yours. The link is waiting for you in the show notes. And now, back to the episode. The next thing that I want to talk about is when we actually perform a bronchoscopy. What are the indications and what other diagnostics might we have performed before we get to that point? Well, like GI endoscopy, a bronchoscopy procedure is usually performed later in the kind of diagnostic process when we're working up airway disease rather than right at the start of it, unless it's something like an inhaled foreign body where we know we need to go in and remove it endoscopically. For most patients, before we've got to the procedure, before we've thought about scoping, these patients will have had a clinical exam, a full history, and as part of that, we need to know how they've responded to previous treatments, so things like bronchodilators, parasite treatment, so if we're thinking about lungworm, for example, antibiotics, things like that. And oftentimes they will also have had things like bloods, infectious disease testing where needed, and also thoracic imaging, be that X-rays or CT. The imaging is really important because it helps us to identify any extra airway disease that could be causing respiratory signs. So for example, we might have a patient who's got pleural space disease or a mediastinal mass that compresses the airway. And in those cases, endoscopy wouldn't really be needed. Instead, we would be sampling that pleural fluid, sampling that mediastinal mass, and then starting appropriate treatment. So we always want to start with the imaging and then move on to endoscopy where it is required. I've also mentioned that a laryngeal exam should be performed in any patient anaesthetised for a respiratory procedure even if we're not, highly suspicious of laryngeal abnormalities or they're not super high on the differential list. The reason for this is that hyperemia, airway secretions and edema around the larynx are all found quite commonly alongside lower airway disease, and they can actually contribute to clinical signs. So we do definitely want to have a look at the larynx before going ahead and having a look at the rest of the airways. On top of this, it's also not always easy to differentiate between a problem with the larynx and a problem with like the trachea or the bronchi from the history alone. And this is especially true in cats. In fact, we had one case a little while ago actually where we suspected that they were asthmatic. They came in with wheezing, for example. We went to do an airway endoscopy and actually found they had laryngeal paralysis secondary to an infection with mycoplasma, which is a common respiratory pathogen in cats. This cat actually ended up needing an emergency tracheostomy, so had very specifically upper airway, like laryngeal signs, but actually they made a full recovery after the mycoplasma was treated. Now, this is not a common occurrence, don't get me wrong. I'm not saying every single cat is going to have something totally different to what we expect, but I am saying that sometimes these patients will throw us curveballs, and so this means that we do need to be prepared for any eventuality. And for me, I'm massively superstitious with stuff like this, as I know most of us in veterinary medicine are. And so I do feel like if we're prepared for everything, then there's a good chance nothing will go wrong. So laryngoscopy is the visual examination of the laryngeal anatomy and its movement, and it's all about assessing the function of the larynx. It's indicated in patients that have upper airway noise, so things like stridor, vocal changes, dysphonia, exercise intolerance and increased effort, especially on inspiration. And the big thing that we're really trying to kind of confirm or rule out in dogs especially is laryngeal paralysis. So this is where one or both of the arytenoid cartilages in the larynx won't actually abduct as the patient breathes in. In cats, the most common laryngeal abnormality that we see is actually edema, with things like tumours and laryngeal paralysis seen sometimes but less frequently compared to dogs. Moving down into the lower airways, the indications classically for bronchoscopy are chronic or acute coughing that either hasn't responded to standard treatment or has no other kind of identifiable obvious cause. Alongside this, things like hemoptysis, so coughing blood, unexplained changes on chest imaging, and also suspected airway foreign bodies are all indications for endoscopic procedures in the lower airways. Bronchoscopy is also really useful for patients with suspected tracheal collapse, or tracheobronchoscopy, I should say, because we're especially interested in the trachea. And the reason that this is great versus something like X-rays is because with endoscopy, we're seeing what's happening inside the trachea in real time as the patient breathes. So it gives us kind of an idea of the dynamic nature of the collapse, because oftentimes what you'll see is as the patient breathes in, breathes out, we will see that collapse kind of becoming more or less apparent. And we're not going to be able to appreciate that from one static X-ray image. So it's really helpful for tracheal collapse patients. Also, alongside this, many patients with tracheal collapse have concurrent bronchial collapse or bronchomalacia. And so being able to look at the bronchi as well as the trachea is really useful. Where bronchoscopy is less useful is in patients that have interstitial lung disease and also in patients with respiratory neoplasia. And the reason for this is these conditions don't do things like shed cells into the airways for us to look at with a bronchoalveolar lavage or cytology brushing. So for those guys, typically we want alternative diagnostic methods. A big part of keeping patients safe during bronchoscopy is also knowing when we should and shouldn't attempt it. So we've talked about the patients that it would be appropriate for, but we also need to talk about when it wouldn't be safe. So bronchoscopy should, where possible, be avoided in patients that have severe obstructive airway disease that can't be stabilised, severe lung disease, so parenchymal disease of the lung tissue itself, or unexplained compromise of either their ventilation or their perfusion. And alongside this, any patient who isn't a safe anaesthetic candidate. And of course, there will be some overlap between those things because A patient with a severe respiratory obstruction that can't be stabilised is not going to be suitable for anaesthesia, for example. Now, as I mentioned, many of these patients do have respiratory compromise. So this means that for us, we need to balance our need for answers to guide treatment with the risks that actually getting those answers will pose to our patient. And that's a difficult judgment call for our clinicians to make sometimes. If our patient is oxygen dependent, for example, and we can't wean them off of oxygen, bronchoscopy is automatically going to be a bit more risky. And this means that in these cases, it should really only be performed where it's absolutely needed. So, for example, if the only way our patient will get better is a treatment that the diagnostic procedure is going to kind of lead us to, that would be appropriate. And this is why proper case selection and also stabilising the patient first by getting them settled in oxygen and reducing stress, things like that, is such a massive part of the procedure. And if we think about it, that's also one of the areas where our role is just so important. Speaking of our role, I really want to kind of bring this home with how we can support patients during bronchoscopy as veterinary nurses and technicians. And I've already mentioned a lot that we're really central to this whole procedure. And please know that I am not underestimating when I say this. Because yes, a bronchoscopy procedure is technically challenging. It requires training and skill, and I'm not taking anything away from that. But the really hard bit is also, a lot of the time, keeping a patient with respiratory disease anaesthetised safely while we do things like partially block their airway with a scope and then introduce fluid into their lungs. And this means that every aspect of our role, from planning to pre-procedure setup to anaesthetic support to recovery, is all really important. Anaesthesia protocols are typically developed based on the individual patient, avoiding drugs that cause respiratory depression where possible or where appropriate. We will also often administer bronchodilators to patients prior to the procedure, especially for cats, and we use terbutaline injection to do this. Now, when you are administering this, of course, under prescription by the vet, this should ideally not be administered intravenously because you will find that this drug causes significant tachycardia. And so for that reason, if possible, it's preferable to give it IM because you won't get as marked like an effect of that. We will typically perform TIVA for maintenance in these patients using something like a propofol or alfaxolone CRI because this allows us to reliably anaesthetise them in the absence of an ET tube while also avoiding things like environmental contamination with a volatile agent. Looking at preparation and pre-oxygenation specifically, I've already mentioned that preparing everything in advance to minimise anaesthetic time is vital, but this becomes even more important in an oxygen-dependent patient because for these guys, we really want to avoid time outside of oxygen as much as we possibly can. So for these cases, we don't want to move the patient for induction until everything is ready to go and the team, the vet, the nurse, the clinician are present at the station, at the anaesthetic machine, ready to start. And also, depending on the size of your hospital, you might need to use something like portable oxygen during the move. So if you need to move your patient from a ward down a corridor and then to the prep room, for example, if they're actually not going to cope well with that journey and that time outside of oxygen, have a portable oxygen source that goes with them. Speaking of oxygen, this is probably the biggest part of monitoring patients throughout the procedure. So the procedure does not begin until you are happy with the anaesthetic and you have a reliable SpO2 reading that's accurate, that's a good trace, that you trust. And if the SpO2 probe comes off or stops reading at all during the procedure, then we should be repositioning it as a priority because none of us, vet, nurse, anyone, we can't tell if that patient is desaturated or not until we trust a result and we've got a good result in front of us. And if that means that the clinician needs to stop for a second while we reposition the probe and we make sure we're happy, then that's what happens because there is no point scoping a patient that is desaturating. There's no point getting answers if it's going to kill the patient. So really, I would go so far as to say that this is kind of a procedure where the nurse is almost in charge because if we're not happy that that scope is going to go down, the vet should not be putting that scope down. It is all led by when we feel that the patient is ready to cope with us causing airway compromise. I personally also like to agree a cut-off SpO2 value before the procedure begins. And this can be really helpful because it gives the entire team a clear stop point. So an SpO2 cutoff is basically where you say, if this patient reaches X% saturation, the team immediately stop, the patient is intubated, they are given 100% oxygen, and then when it comes back up again, we will repeat. So you might particularly say, for example, that this patient that you're scoping right in front of you, you all agree as a team, the vet and the nurse, that if the patient reaches 92% saturation, everyone stops, the scope comes out and the patient is reintubated. And then as we're happy, we will carry on. And that continues until the entire anaesthetic and procedure is finished. Throughout that entire anaesthetic, we are continually watching the patient, we're watching the SpO2, we are communicating about how the patient is doing so that the clinician knows how much time that they've got to do the procedure before they need to come out and when it's safe for them to go again. Alongside this, we also need to talk about airway access and also emergency planning, both pre and post procedure. So this is important because we can't perform the majority of bronchoscopies intubated. So our small dogs, cats, for example, they will need to be extubated for the procedure. And this means that we can't reliably administer oxygen to them. So we need to think about other ways of getting oxygen into them outside of an ET tube and get a bit creative with this. And one way is to use something like a rigid urinary catheter alongside the endoscope in the trachea to administer supplemental oxygen. So to do this, a rigid urinary catheter would be introduced into the airway the same way as an ET tube would be. When we're doing this, we need to measure, make sure that we are not advancing the catheter too far, because if it ends up in one lung, then we're only going to have one lung receiving oxygen and one lung not. So making sure that we're measuring to like the thoracic inlet, for example, and not advancing past then. And then that catheter should then be attached to an ET tube connector and a breathing circuit. In larger patients, so ones where, we're placing ET tubes of 6.5 and above, where there's a bit more diameter, those guys can actually have the bronchoscope through the middle of the ET tube. This allows us to keep delivering oxygen reliably throughout the procedure, and we do this by adding an elbow connector with a little kind of self-sealing port on the end of it over the end of the ET tube. We do need to bear in mind though, if we are using this, that connector is going to increase dead space a little bit. Might be something to monitor, but usually it's not too much of a problem, especially versus, not being able to give them as much oxygen. For me personally as well, I also like to keep a variety of ET tube sizes alongside tube ties and also a mask on hand, along with a bit of kind of extra induction agent drawn up to allow rapid reintubation if needed, either during the procedure itself or in recovery. And also alongside this, I tend to keep a stack of large cotton buds and also suction if available on hand, just in case I need it to clear any respiratory secretions, especially from around the larynx, at the end of the procedure as the patient recovers. In terms of positioning and sampling, the patient should be positioned in sternal recumbency with the neck extended. This is going to elongate the trachea and make the procedure easier and therefore quicker for the clinician. And also in recovery, that nice elongated trachea is going to make it nice and easy for our patients to breathe as well. We're going to need to use a gag to protect the scope from bite damage, and this needs to stay in place at all times. Or for cats, because we don't use spring-loaded gags for these guys, we will use something like a cut-down needle cap. And then looking at our role as veterinary nurses, during the BAL, we are often the ones doing things like applying coupage to the chest to help mobilise cells and kind of pathogens, bacteria, etc. into the fluid, and then also handling the suction to retrieve it. And also afterwards, that sample handling and submission are going to be our responsibility as well. At the end of the procedure, the patient should then be re-intubated and kept on 100% oxygen until they are stable, and then recovered somewhere quiet with as little stimulation as possible. They should be monitored closely for several hours with supplemental oxygen if needed, either with flow-by or an oxygen tent or oxygen kennel, for example. In the kind of post-procedure monitoring for these patients, if you are auscultating the chest, you may hear some focal crackles at the BAL site for a few hours afterwards. If you hear this, but there's not kind of diffuse crackles and the patient is otherwise okay, this is usually just from the BAL fluid and not typically a concern. But what we do want to watch out for, though, are things like changes in respiratory rate, desaturation, respiratory pattern, effort, or any other general worries that you may have with the patient. In cats particularly, bronchospasm in recovery is a really important consideration to look for. And that's why I like to keep an emergency airway tray with these patients as they recover. So in this tray, I keep flush, a small amount of induction agent, a laryngoscope, and equipment for reintubation. And I will also maintain patent IV access in these patients until they are ready to go home, or we're super happy with their recovery and not expecting anything else to happen. Upper airway obstruction can also occur in both our cats and dogs due to things like laryngeal edema, swelling after a biopsy, or maybe from a pre-existing lesion if there's been some abnormalities at the larynx, or a buildup of secretions, or even things like bronchoconstriction. If airway swelling is a risk, then dexamethasone, so intravenous steroid, is often administered. And also in some cases, if bronchoconstriction is a concern, then terbutaline may also be repeated. In all cases, for me personally, I would pre-calculate doses of these and also have these drugs within easy reach in case of complications if I'm concerned on recovery. Firstly, because hopefully that means I won't need it if I've prepared for it, but also if I do need it, it's right there, we're not wasting time, and we can get those drugs into the patient under veterinary direction nice and quickly. And don't get me wrong, none of this is acting outside of the legal scope of our role as veterinary nurses or technicians. We are not administering medications, but what we are doing is getting a pre-authorised, pre-calculated dose from the vet and having the drugs nearby so that we are prepared in case an emergency intervention is needed. And similarly, with securing airway access, we are getting things ready, drawing up induction agent, preparing for intubation in case that's needed. Knowing what to look out for in these patients really allows us to ensure their safety and also adapt our nursing care to their specific needs and to this specific procedure. And all of this allows us to use more of our skills. So there you have it. That is lower airway endoscopy and how we manage it as veterinary nurses and technicians. Now, this was a longer episode, so before we wrap up, I do just want to give you a super quick summary of the most important points of what we've discussed, just so you leave with all of that information kind of front of mind. So bronchoscopy is commonly used to investigate coughing, abnormal respiratory pattern or respiratory noise, hemoptysis, foreign bodies, and tracheal collapse, amongst other things. Because of this, pretty much all of these patients will have some degree of existing respiratory compromise, and even stable patients can decompensate. So preparation, anaesthetic support, and stabilisation are absolutely vital nursing considerations. The whole procedure involves examination of the larynx, the trachea, the bronchi and bronchioles, and then systematically looking at that across both lungs with sample collection as needed. And it's usually performed in short, sharp bursts with reoxygenation time depending on the individual patient. The scope's performed using a flexible bronchoscope with many of the same handling, care and use considerations as the GI scope that we discussed last week. It's just a little bit of a simpler piece of kit versus a gastroscope. And these patients really need us as veterinary nurses and technicians for the procedure to be successful. We're stabilising them beforehand, pre-oxygenating them, working with our vets to collaborate on anaesthesia protocols, protecting the airway and protecting the scope, keeping them oxygenated by whatever route kind of suits their size. That's either going to be a urinary catheter or through the ET tube. Watching their saturation really carefully, applying coupage during a BAL, handling the samples, and then continuing that care in recovery. And all of this means that there are many, many more ways to nurse these patients than just setting up the scope and just monitoring the anaesthetic, and I'm air quoting very hard. And that means that there are lots of skills that we can use in the process. So that just leaves me to say a massive thank you for joining me for today's episode. I really hope that this has helped you with new ways that you can support your patients during these airway investigations, looking at the importance of your role as a veterinary nurse or technician in supporting these cases, and they really are such a nurse-led procedure, because if we're not happy, then that procedure can't continue. I would love to know, as always, about the cases you're seeing and also what you're running into in practice with your bronchoscopy patients. Are they going okay? Have you found them challenging? What do your anaesthesia protocols look like? What problems do you run into? Do you intubate them? Do you not? What do you use to give them oxygen? Do you have set protocols for supporting bronchoscopy GAs? Or is that something that you want to develop in your practice? Pop me a message, let me know. I love chatting with you and I would love to help you do that. As always, if you have found the episode helpful, please do consider sharing it with a friend or colleague who would also be helped by this, and make sure that you are subscribed to the podcast on your podcast playing app. A massive thank you once again for being here and choosing to learn with me for another week, and I look forward to speaking to you next week. Bye. If you've made it this far, then thank you so much for listening all the way to the end of the episode. And I have one more thing to ask of you before you go today. I would love to hear from you. Yes, you. I love hearing about the cases that you're seeing, the skills that you're using, and the conditions that you want to learn more about. Drop me a DM on Instagram. I'm at Vet Internal Medicine Nursing, and don't be shy. Come on over, say hello, and tell me a bit more about you. Talk to you soon.